topic of small bowel obstruction. So I've picked a number of cases that I think are instructive and that can help us to analyze these cases logically and make some important distinctions that are helpful for our surgical colleagues. We're going to practice some critical analysis of small bowel obstruction cases here. One of the key things that I hope to help you all with is to be able to better differentiate closed loop small bowel obstructions from conventional obstructions that have a single transition point, because a true closed loop obstruction in almost all cases is a surgical diagnosis. We will also talk about some of the imaging features that are concerning for infarcted bowel or bowel at risk for infarcting if not treated rapidly. So, first case. Here we have our axial images. You can see that there is a large left-sided ventral hernia with a fairly wide neck right here. And we have some distended, fluid-filled loops of bowel. And our job now that we think that there's a bowel obstruction is to find the transition point. So we pick a bowel loop, say we pick this one, and we go in one direction and follow it out and come in the other direction. And we find this bit here that has some fecalized contents. This is a very helpful sign. If you need to go quickly, you jump to the area that's fecalized, and more often than not, that is immediately proximal to the transition point. So let's do that again in this case. We can see that right here, we go from this loop, and we come down into this area of relative wall thickening, and then beyond that, we are in decompressed small bowel loops distally. So we have found the transition point here. On our coronal images, we can do the same thing. Here, we're going to find that fecalized loop. There it is right in the center of the image. We can see this area here with a bit of thickening, and then here you can see again a nice target sign from some edema within the wall, and then it comes down into decompressed loops. So this is a classic small bowel obstruction with a single point of transition. This is not a closed loop bowel obstruction. Most common causes of a single transition point bowel obstruction are adhesions from prior surgery, or occasionally from other inflammatory processes that have happened previously in the abdomen. One thing that's helpful to think about here, this is a bit odd. I don't see a very tight narrowing to suggest an adhesion, and I see this unusual edema pattern in the wall right there. And what I actually think happened here is that this area of bowel was likely impacted on the wall of this large ventral hernia right here about an hour or so before the scan. The unfortunate thing about CT is we're imaging at only one point in time, and we have to infer what happened before this. And so I think sometimes when I see something like this with a focal area of edema that doesn't make sense, I try to think what might have caused that. And one possibility, it's pure theory, no one can ever prove me wrong, so it's a good theory, is that this was transiently impinged on the wall of the hernia as a source for this bowel obstruction. These bowel obstructions with a single point of transition are often managed conservatively by our surgeons. More and more lately than at the beginning of my career, very few of these patients end up going to the operating room if their clinical exam is good and we don't see suspicious findings for bowel infarction or impending bowel infarction. So our job as radiologists are to differentiate those cases that need to go to the operating room more urgently. Let's move on to another case. Here we clearly have a bunch of fluid distended small bowel loops. We are searching and searching for our transition point. We haven't found it yet. But we can see that we do have some decompressed small bowel loops over here in the left side of the abdomen. If we follow this loop now, we can see right here that it becomes quite narrow. And here we have two very narrow loops of bowel leading into this obturator hernia immediately beneath the superior pubic ramus. Here it is here on our coronal images. You can see right here is our transition point coming into this small, very small knuckle of small bowel in this obturator hernia, and we have decompressed loops coming out of that hernia and coming back into the abdomen. So again, single point of transition here, but unless something is done for this, unlike an adhesive small bowel obstruction or an edematous small bowel obstruction, this will not improve. So the surgeon will often try to manually reduce hernias that are causing small bowel obstruction, but if they can't do that, even though this is a fairly conventional bowel obstruction, this patient will go to the OR in order to reduce this and salvage bowel. Now, the question is, do we see any signs concerning for bowel infarction here? I do not. We have a nice, relatively thin small bowel wall here. We do not have very much mesenteric stranding. We do not have a significant amount of ascites, and we have what appears to be nice uniform enhancement of the bowel wall. These are all very reassuring signs. If it weren't for the fact that this was caused by a hernia that was not reduced, this patient would be a great candidate for conservative management. Let's move on to another case. Here we already see some ascites up here around the liver. As we come down lower, we see a portion of bowel, a bit of a noisy scan, but we can see a portion of bowel over here that is fluid-filled, that is distended. And one of the things that's interesting about this bowel is you can imagine all of this bowel sits in a sack. This is a bag of bowel, right? It all points with radial folds to this region here. So these findings alone make us very suspicious that we're looking at a closed loop bowel obstruction. Let's look at it on coronals here. Here again, you can see all of these abnormal bowel loops all together here, all pointing towards this area of mesentery right here. Highly suspicious for a closed loop obstruction. Our job, though, is to actually find 2 points of obstruction, 2 transition points, and they need to be close to one another. The pathology or pathophysiology of a closed loop bowel obstruction is either an internal hernia where we have a small gap in the mesentery, usually postoperative, rarely due to other causes, that a loop of bowel can come through, and we have bowel pass through this little hole. And so therefore, we must have 2 adjacent small bowel loops that are compressed. The other option is that we have an adhesion form, usually from prior surgery, between 2 loops of bowel, and we have torsion or volvulus around that adhesion, in which case, again, these 2 loops of bowel both have transition points immediately adjacent to one another. So let's look at this case. We know that we're looking for transition points right in this region because all of these edematous mesenteric folds are pointing to that area, and it can be a little bit difficult. This is part of the reason I come with clips, but if you follow this loop right here and follow it down right here, you start to see that transition point. Let me find just the right image to this decompressed small bowel loop. That's number 1. If we find that on this image here, it is this loop of bowel right here. We follow that down, and you can see it comes down to this very small decompressed loop. So we found 1 transition point. Now we need to find the other, and this is a little tricky to do, but this is it right here. So they're very close to one another. I cannot tell from CT whether this is an internal hernia or whether this is a volvulus around an adhesion, and it doesn't matter. This is a closed loop bowel obstruction. This is a surgical case. But what we can help our surgeons with then is additional findings of concern to help give them a sense of urgency for how rapidly they need to go to the OR for these cases. And this patient has some concerning findings. We have here a large amount of mesenteric fat stranding or engorgement. We have some wall thickening of these affected loops here. And there's a suggestion that we have differential mucosal enhancement. We do see a little bit of iodine enhancement in the wall here, but if we compare to the distal loops that are decompressed, you can see that there's much more avid enhancement here. So maybe we can see this better on our coronal images. Here, we see this looks a bit dusky. It looks like it has a bit of diminished enhancement, compared to these decompressed loops distally. This is one of the reasons we don't like to give oral contrast for small bowel obstruction, because we have no ability in these loops that contain oral contrast to tell how well the wall enhances. And so one of the concerns when we stopped using oral contrast that people had was, well, don't you want this for small bowel obstruction? And I would argue, actually, this is a case where we do not want oral contrast. Traditionally, because we're obstructed, the oral contrast doesn't make it anywhere close to our transition point unless we wait a very long time. And secondarily, it is very helpful, I think, to be able to compare the enhancement of the normal bowel to the enhancement of the affected bowel. So this one I would read as being concerning for compromised bowel or bowel at risk for infarction. Let's move on to another case. All right, very similar location, very similar appearance of a bag of bowel here, all self-contained with these folds immediately next to one another. And these radial folds, again, point to this similar location here. Here we can see it on our coronal images as well. We have a calcified structure here. We're not sure what that is. Turns out that this patient has not had prior surgery. So this is very unusual to see a small bowel obstruction in a patient with no prior surgery. The presence of this calcification made us question whether this might be an appendicolith. Perhaps this is an adhesion from a prior subclinical appendicitis. Perhaps this is an adhesion from a previous Meckel's diverticulitis that contains a calcification as well. We don't actually know. Here, though, if we go to our coronal images, again, we see these loops of bowel. We see them pointing to this area. And if you look at this loop right here, we have a very abrupt transition point from distended bowel to decompressed bowel right here. We're looking for an adjacent loop that I need to now find for you, which is difficult to do. You might have to take my word for this one, that there are two adjacent transition points, again, very closely positioned at the apex of those radial folds. Other features, we have, again, these very abnormally thickened small bowel loops. We have a large amount of mesenteric inflammation here, perhaps due to venous congestion, perhaps due to ischemia. This is a concerning appearance. Now here we happen to do this patient with a dual energy acquisition, and I hope I can convince you that there is no orange color within these loops compared to the distal loops. Tough case because we don't see a large amount of enhancement within the distal loops either here. We certainly do see some enhancement in the jejunum, but it's quite common to see a bit more iodine content within the wall of the jejunum than the ileum. So we do want to compare with a similar portion of the bowel. Regardless, I don't see any orange color here, highly concerning for dead bowel or nearly dead bowel confirmed at surgery to be infarcted. I think this patient needed a large portion of their bowel resected. Okay, let's move on. Here's another case. Very similar appearance. We have many fluid distended small bowel loops. We have a large amount of mesenteric engorgement. This is concerning. Let's find our transition points. Well, focus on this loop here, right here, as I follow this down, and you can see that it collapses right there down to nothing. There's one transition point. Let's try to find the other. I'm still looking. Here it is. Let's find this loop right here. Follow this loop down here, and you can see it collapses down right here into this very flat portion here. As we look at this in the sagittal images, you can see this loop right here transitioning down flat right here into this decompressed loop. That's one. And on the other side, here is number two. You can see this transition point from distended to non-distended. Both of these transition points right next to each other. Internal hernia, volvulus around an adhesion, In a similar way here, we have a lot of mesenteric engorgement. We have a good quantity of ascites. This, to me, is a concerning case. Although, on the other hand, if you look at the wall enhancement, we have a reasonable amount of wall enhancement at this point. This is likely salvageable bowel, I would guess. All right, next case. Here we see some fluid-filled bowel loops. Here we see an area of fecalization, so we're going to follow that. As we follow that, we come down right here to our transition point. We have decompressed bowel beyond. So we've found a transition point. Do we find a second? Not really. I couldn't find a second. Does this bowel look like a well-contained sac full of obstructed bowel like those other cases that I showed you? Not so much. We certainly see that it's all, a portion of bowel, but that's what we expect. Everything proximal to the transition point should distend, but it really doesn't have that same classic look that I showed you before of closed-loop obstruction. So this looks to be a single point of transition here. Now, this one, I will say, coming back here, I was a bit concerned about this due to the degree of wall thickening here and due to some of the enhancement. But again, this was a case where we had a dual energy CT. Here on the coronal images, if we come and follow this fecalized loop again, we can see the point of transition right here. And if we look at our dual energy CT, we can here see our iodine enhancement within the wall pretty nicely, and it looks rather comparable to the decompressed normal distal small bowel loops. And this, in fact, was viable bowel. We know this because what we often do here in these patients with small bowel obstruction who do not have a very concerning clinical picture is our surgeons have developed a pathway now. After we make the diagnosis of CT without oral contrast, the surgeons give the patient full undiluted contrast by mouth. They wait typically 8 hours and they do an x-ray of the abdomen. The goal of this x-ray is to see whether this contrast has passed into the cecum, which indicates to us that this is a partial small bowel obstruction. Well, I don't see any contrast in the colon at this time. We see some valvulae coniventes here in small bowel loops. This appears to all be oral contrast within the small bowel. The patient still is doing reasonably well clinically, so as part of this pathway, the patient then gets typically a 24-hour CT. And here you can see, a little bit difficult, but you can see that there is some contrast now that has made it into the colon here at 24 hours. This patient does not need surgery. So we have proven with distal passage of contrast that this was either a partial or a transient small bowel obstruction, and this patient can avoid surgery. That was a little bit of a surprise to me from that CT scan because there were a few concerning features, though again, we did have good bowel enhancement, we did not have tremendous mesenteric engorgement, and we did not have a large quantity of ascites. So those are some of the key findings that we like to think about as being ones that are concerning. Let's move to another case. All right, here we go. So, bowel obstruction, yes. We have distended small bowel loops. We're looking for our transition point. If we follow this out, we see some area of fecalization here, and we see that we come to a very focal transition point right here. Here it is on our coronal images. Right here is our transition point. It, in fact, does not look terribly severe. I can actually see contents passing through this relative area of narrowing, and we can even see some fluid beyond. This was the only transition point. So this is a single point of transition. It does not have concerning or suspicious features for bowel infarction here, and this patient, again, was managed conservatively and did fine. Now, what I didn't tell you is that this patient had a history of appendiceal carcinoma. And what you can see here is a bit of focally increased enhancement right here at this point of transition, which is thought to represent a serosal implant as one feature of peritoneal carcinomatosis in this patient. And this patient was simply followed over time as his peritoneal carcinomatosis became worse, but the small bowel obstruction at least did not require any intervention. All right, next case. So here we have what looks to be some distended small bowel loops proximally here, some decompressed small bowel loops distally. Our radiologist read this as small bowel obstruction. Here it is here. As you can see though, as we come here, we have a very gradual tapering of small bowel to decompressed caliber here and relatively distended up here. This is another reason why I do not like giving oral contrast for small bowel obstruction, because what we're seeing here is simply transient distension of the proximal small bowel from this large volume of oral contrast that the patient is drinking quickly for our CT scan. And so you're seeing it distend the duodenum and the proximal jejunum, and as we run out of our oral contrast bolus, the caliber of the small bowel decreases. So this, I think, is purely an artifact from the patient swallowing a large volume of contrast. But unfortunately, this was called a small bowel obstruction. This case was from some time ago, before our oral contrast challenge algorithm. And this patient ended up actually getting a CT scan at 24 hours. And as you can see here, the bowel is all completely normal caliber with contrast passing into the colon. No small bowel obstruction at this point, and I would argue, though no one can prove it, that there was likely no small bowel obstruction even on the initial CT scan. So just a word of caution, if you're giving oral contrast, to pay attention to the distribution of the contrast relative to the caliber of the small bowel loops, because it might just be a transient phenomenon. How am I on time? 7 minutes. Okay, perfect. All right, here's a patient. These are the planning projection radiographs from the CT scan. You can see here that we have multiple small bowel loops that are fluid distended. On the lateral view, you can see a few fluid levels in here. So we're thinking small bowel obstruction. And we get our CT scan, and we see that we have a number of fluid distended small bowel loops, some of which contain fluid levels. We search for a transition point and don't really find a clear one. There certainly are some decompressed distal small bowel loops here, but no focal transition point. And so what do we do with this case? Well, this is a little bit of a pitfall here. One of the features that you might notice here is that the wall of these small bowel loops are incredibly thin. They're paper thin. They're not thickened like many of the other small bowel obstruction cases I showed you. You might look through these cases and think, maybe this represents pneumatosis here. I'm not convinced. I think this is very easily gas trapped beneath the valvulae conniventis. But what this actually represents is small bowel ischemia. And this can be a very challenging diagnosis on CT, particularly on a non-contrast CT like this, where we cannot assess the vasculature. But one of the ways that the small bowel commonly reacts to primary ischemia from a vascular cause is it gets atonic, distended, very thin wall. It simply does not peristalse as normal. And one thing to keep in mind when you see something like this is that this might represent bowel ischemia rather than bowel obstruction. Obviously, these have very different management implications and implications for the patient, so it can be helpful to keep this in mind. All right, let's move on. Here, again, is another case. We have what to me looks like a bag of bowel that is thickened. We have mesenteric stranding. We have some pointing of these radial folds towards this region here. Let's look at it on the coronals, And here's another finding that I didn't talk about before, which is look at the mesentery and look at the vasculature. And this is the so-called mesenteric whirl or swirl. As things are being distorted, as the mesentery is being distorted, usually by an internal hernia or a volvulus around an adhesion. So this is another very helpful finding. Our job next is to look at our transition points. Here are 2 bits of decompressed small bowel leading into this area where we have our distended loops. So this is another closed loop bowel obstruction, just with another finding that we didn't talk about, this mesenteric swirl or whirl sign. All right, I want to talk about a couple of special cases. We do a lot of weight loss reduction surgery in the US, probably not quite so common here, but we do a very large amount of it. So let me just briefly review the anatomy and some of the small bowel obstructions that you need to think about in this case. In the traditional Roux-en-Y gastric bypass, what the surgeon does is they put a staple line across the stomach, excluding this portion of the stomach from the small remaining gastric pouch. They have then the duodenum and the proximal jejunum. Its only function then is to drain gastric secretions, pancreatic enzymes, and bile. So that is called the pancreaticobiliary limb. The jejunum is then divided, and this portion of jejunum, the roux limb, is brought up and anastomosed to the gastric pouch to form the gastrojejunostomy. And the pancreaticobiliary limb is then anastomosed to the side of a distal jejunal loop to form the jejunal anastomosis. So we have the pancreaticobiliary limb, sometimes called the afferent limb, and we have the roux limb, which is draining the ingested material. In this case, we have potential to have different types of obstructions. We can obstruct the pancreaticobiliary limb, we can obstruct the roux limb, or we can obstruct the common channel beneath. And depending on where the point of obstruction is, we'll see distension of a different loop. So let's look at this case here. This is a Roux-en-Y gastric bypass. Up here, you can see the staple line across the stomach. This is now the excluded portion of the stomach that is filled with fluid. The gastrojejunostomy is here, and this is the roux limb now that we can somewhat follow down distally, although we start to lose it there. And as we come down lower, we see a funny appearance here of a lot of mesenteric engorgement down here. We can see this as well on our coronal images, where we see a lot of mesenteric engorgement. We don't actually see bowel obstruction, right? We do not see distended small bowel loops here. But one of the very concerning things that can happen after bariatric surgery is we can have internal hernias. We have created holes in the mesentery that bowel can pass through, and we can have internal hernias that are a surgical emergency even without seeing obstruction of those small bowel loops. Some of the findings that you can see here are that the anastomosis, the staple line from our jejunostomy, is here, down in the right lower quadrant. Normally, it belongs here in the left mid-abdomen. And so we have moved this jejunal anastomosis to a part of the patient's anatomy where it does not belong. We have a lot of mesenteric engorgement. And let me show you another finding. Let's follow the superior mesenteric vein down. So here we have our portal vein. We have our portosplenic confluence. And if we head inferiorly from there, we can see we have our SMV here. Let's follow the SMV down. We come down and it collapses down to nothing. And here is our mesenteric swirl. Does everybody see it? So we are wrapping our superior mesenteric vein around our superior mesenteric artery for at least a 360-degree rotation here. And this is why we have all of this mesenteric engorgement, because we have venous obstruction draining these bowel loops. So this is an interesting case because we've got venous obstruction without actually having bowel obstruction to the point that it's distended. Either way, highly concerning. This patient needs immediate bariatric surgery to correct this. Let's move on to another case. This patient has actually had a a gastric resection for gastric cancer. But other than that, the anatomy is very similar to what I showed you for the gastric bypass. We have here an anastomosis from a jejunostomy. So we have a roux limb that is draining ingested contents here. You can see a bit of oral contrast in this non-distended jejunal roux loop. Here is the normal position of the jejunostomy in the left upper or mid abdomen. And so where are all of these other fluid distended loops here? Well, this is the end staple line from the pancreaticobiliary limb or the duodenum. We can, we can follow that down here, and as we trace these loops out, we finally can get to an area right near this jejunostomy. This represents obstruction of that pancreaticobiliary limb. So ingested material has no problem passing distally. In fact, we can see it here in distal small bowel loops. Here it is on the coronal images. We see all of these distended loops here that come down and transition somewhere right in this region. The reason I show you this case is that if we have obstruction of the pancreaticobiliary limb, even though we have only one point of obstruction here, proximal to the jejunal anastomosis, this represents a closed loop obstruction because there is no way to drain this loop. We saw here that we have a blind ending duodenum right here. There's a staple line across it. If this were a traditional gastric bypass patient, we would have that staple line across the stomach, but either way, there's no way to drain that from above with an enteric tube. Similarly, there's no way to get to this from below. So the only way to drain this distended bowel loop is to treat this surgically, unless you were willing to put a percutaneous drain into the bowel through the skin, which nobody's interested in doing, because then that makes a hole in the bowel that tends to stay there. So this is also a surgical emergency, closed loop bowel obstruction from a gastric bypass patient. Let me show, I think, one more patient. This is another patient who has had a gastrectomy, and we see a lot of distended loops here. You see this anastomosis right here. This is our jejunostomy anastomosis from that roux limb connecting to the pancreaticobiliary limb. We see here that we have distension of the pancreaticobiliary limb. Here it is, wrapping around here. That's the duodenal C-sweep. We can follow that down here to our jejunostomy. We see our jejunostomy itself is distended. Let's come farther this way. This is our roux limb coming down, which anastomoses here to our jejunostomy, so that's not obstructed. And only if we, a little hard to navigate these videos, only if we follow more distally through our common channel here can we see that we have a point of obstruction in the common channel distending both sides. This is going to be treated surgically. Technically not a closed loop obstruction because that pancreaticobiliary limb could drain into the roux limb and could conceivably be drained from above with an NG tube, but not terribly commonly done. This would typically have a repair. Let me just see how am I for time now? Out of time. Okay, let's stop there. Does anybody have any questions about small bowel obstruction? My goal here was to try to make us all a little bit more confident in diagnosing closed loop compared to single transition point bowel obstructions, and to start thinking about some of the features that are very concerning in terms of bowel at risk that needs more emergent surgery. Any questions? Okay, it's break time. I have one more lecture for you afterwards on non-traumatic chest emergencies, also mostly case-based like this one. Thank you.
We will have a short coffee break, and I'd like to remind our audience to fill in the surveys. And if you have bring one in first, it would be greatly appreciated. And we would like everyone to be seated by 3 o'clock. Thank you.